So I'm going to take the moment to introduce Krystal here. So Krystal Chase is a licensed social worker and certified brain injury specialist with more than 10 years experience working with individuals with substance use disorder and more than 5 years experience working directly with individuals with brain injuries. Previously, she worked in both inpatient and outpatient settings, primarily for individuals with chronic mental illness and/or substance use disorder, and has served as the Director of Programs and Services at the Brain Injury Association of New Hampshire for the last 5 years, where she has overseen case management services for individuals under long-term care Medicaid waiver programs. Her primary focus within the field of brain injury is with the intersection of substance use disorder related to substance use, including brain injuries sustained as a result of one or more overdoses. Without further ado, thank you, Krystal. Take it away.
Thank you guys so much for being here. Even though half the room is my staff, but I may or may not have threatened to show up here. So thank you so much. As she mentioned in the introduction, prior to working at the Brain Injury Association, I had worked extensively with individuals with substance use disorder as well as chronic mental illness. I did level of care evaluations for our rehab and detox center. I did partial hospitalization programs where I ran groups. So I was thankful when we started working on some grants that I'll talk about in the presentation at the Brain Injury Association to combine that with working with individuals with brain injuries. So what we're going to talk about today, actually, if you were in the first two presentations, they fed perfectly into what I'm going to talk about. And we didn't really coordinate that, so that worked out well. We're going to talk about the intersection between brain injuries and substance use disorder. It's a lot more common than you think. The first and second presenter both talked a little bit about overdose and the impacts on the brain, and now I'm going to talk about kind of those long-term effects that you might see in individuals that you're working with, things that you might see in somebody if you're providing any kind of substance use treatment to them. So just one thing to think about, in an overdose situation, what happens? You live or you die, right? Mm-hmm. So people that live are surviving, and surviving with effects of brain injury symptoms due to the lack of oxygen to the brain. So today, I'm hoping that by the end of this, you'll be able to explain the connection, that you'll be able to identify how an individual might have a brain injury, maybe some of the symptoms that they have as a result of that, and then that you'll learn some strategies to work effectively with that population in whatever setting that it might be. The presentation that I do, it's kind of geared more towards folks that work in a direct substance use disorder treatment program, but really the stuff that I'm going to talk about you can use in any setting. So I just want to kind of a quick show of hands. How many people work with individuals with a substance use disorder now?
Yeah.
And how many work with brain injuries? And Peter Fifield kind of stole my thunder on this, so if you remember it from the first presentation, what do you think is the approximate amount of individuals who have both the substance use disorder and the brain injury? Guesses?
50%?
It is 50%.
Oh,
And how do you think they got the brain injuries? I talked about overdose a little bit, but what are maybe some other things?
Like car accidents, falls.
Yep. What else?
Attempted suicide.
I'm not going to talk about that, but that is definitely one. Well, you're going to learn about some more. All right, so I think I have a group of brain injury professionals here that kind of know these things, so I'm going to try to breeze through some of these slides. But we have, different types of brain injuries. An acquired brain injury, in general terms, is a brain injury that you've sustained after birth. So it's not as a result of birth trauma, it's not hereditary, it's not congenital, it's happened after birth. We have traumatic brain injuries, which is what most people are familiar with, and then non-traumatic brain injuries. Sometimes non-traumatic brain injuries are referred to as acquired brain injuries, but they're both acquired brain injuries. So traumatic brain injury, bump or blow to the head, so something caused by an external force like a fall, car accident. A non-traumatic brain injury is internal, so lack of oxygen or some type of disease process that affects the brain functioning. So here are some different causes of brain injury. So traumatic brain injury being, like I said, one of the more common ones that people are aware of, usually related to falls. And concussion, obviously sports and recreation, but there are some others. gunshot wounds, domestic violence, military action, so from IED devices, non-traumatic brain injury, lack of oxygen, which we'll talk about related to drug overdose, as well as stroke. You can read the meningitis, seizures, any kind of tumors, brain tumors where it's putting pressure on the brain, brain aneurysms, neurotoxic poisoning. Okay, so overdose. An overdose can cause a brain injury. Not all overdoses result in a brain injury, but they all have the potential to result in a brain injury. And the reason for that, if you were in the last session, we learned a little bit about how an opioid attaches to the neurons in the brain and how it slows those neurons and prevents them from being able to fire appropriately. So most of the time in an overdose situation, you experience respiratory depression. So you stop breathing, things all kind of start to slow down. Well, oxygen is no longer getting to your brain when your breathing is slowing, and it can either inhibit oxygen to the brain completely, or it can just slow it down. So this could lead to an hypoxic anoxic injury. So anoxic is complete lack of oxygen. Hypoxic is just a diminished amount of oxygen. So how are the two connected, and why is it important to make that connection? Because, like I said in the beginning, individuals are overdosing, and we have more individuals surviving overdoses thanks to Narcan and thanks to other types of treatment. But now we're seeing people that might have kind of lifelong or at least extended symptoms of brain injury that maybe they hadn't thought about before, maybe they hadn't experienced before. So anecdotally, I worked at St. Joseph Hospital in the emergency department. I evaluated individuals who had had overdose and individuals presenting with psychiatric concerns. And one person in particular always stands out to me. I saw him after his first overdose. He was okay. Came in, we revived him. He didn't want to stay. He took off, he left, that's fine. Comes in after another overdose, kind of the same thing. But by the 5th time that I saw him, he was so different. He was like a different person. And it wasn't just the effects of the substance use. You could tell cognitively that he was not processing the same information that I had previously given to him on previous ER visits. So we saw over time the change, and if you work with brain injuries, you know that they're cumulative, that they build upon each other over time. But just over time with this person, we just saw such a marked difference in his ability to receive the information that we were giving him, and which would affect his ability to participate meaningfully in substance use treatment. So 90%, this comes from BIAA, 90% of all overdose patients suffer some level of brain trauma, and it might be temporary and short-lived. If you don't have oxygen going to the brain, you're gonna have some residual effects, even if it's just for that day, a few days after, a week after. And some people experience that for a lot longer. And just the lack of awareness, the main reason that I do this, that I do these types of trainings, is to just make that connection and help people to see that there is a connection between brain injury and overdose. And the folks that you are working with, more than in the substance use disorder treatment setting, more than likely have a brain injury. Okay. So, evidence suggests that having one or more brain injuries, especially ones with loss of consciousness, put individuals at greater risk for developing a substance use disorder and other mental health disorders. So the issue with substance use disorder and brain injury is they feed into one another. So people with brain injuries are more likely to have a substance use disorder, and people with a substance use disorder are more likely to have brain injuries. If you have a brain injury or history of brain injury, it's associated with starting to use drugs or alcohol earlier in life and having that last a lot longer than somebody who maybe doesn't have a brain injury. And substance use is obviously a risk factor. As we talked about falls, DUIs, car accidents. So between 23 and 51% of adolescents and adults were intoxicated when the injury occurred. And if you work in any kind of physical rehabilitation setting, this might be very familiar to you. Approximately 25% of people hospitalized for traumatic brain injury have a history of substance use disorder. I actually think it's probably higher than that, but like a lot of things, it's underreported. So we would talk about this, so different types of brain injuries related to substance use. We talked about overdose. Has anybody ever met somebody with wet brain? it's pretty significant when you work with somebody with that. So wet brain or Wernicke-Korsakoff's. So it affects the person's physical abilities, their balance, but it also affects their cognitive abilities. Some of them might have some psychosis, lots of up and down mood changes, confusion, and that's from just chronic long-term alcohol use. That's not any kind of acute brain injury. It's just from abusing alcohol for so many years that you put your brain through all of that trauma. Individuals who use alcohol consistently, enough that they would require a medical detox, if they don't receive a medical detox, they can develop seizures from alcohol withdrawal. So individuals who have had seizures from withdrawal, that's another brain injury. And then like we talked about, traumatic brain injuries related to use. One that I think is underrepresented is individuals who might get into assaults or fights as a result of their use. We did have somebody that we worked with a very, very severe brain injury that had gotten into a fight outside of a bar while he was intoxicated. Pretty young too, I think he was in his early 20s, and lifelong effects from that. Okay. What do we see when somebody has a brain injury? I think those of you that work with these folks, you probably see this all the time. Short-term memory loss, decreased focus, inability to form new memories, difficulty with word finding, difficulty with reading social cues and kind of following societal norms, starting a task and then following through on a task, following it to completion. Apraxia, so inability to execute a familiar sequence of physical movements. So think about washing your hands and all the steps that are involved with washing your hands. So you have to turn the water on, you have to get the soap, you wash your hands, you use the towel. So somebody might cognitively know how to do that, but have challenges actually executing that in the sequence that it's supposed to go in. And one of the biggest things that we see with brain injuries is behavioral or emotional dysregulation. And these are the things that are probably the most challenging for us as brain injury providers or substance use disorder clinicians to deal with. Because we see a lot of challenges with people who might have anger, they might be impulsive, they might be a completely different person than you knew before. I had a friend, unfortunately, he passed away from a brain tumor. He was actually not really a nice person before, and he developed the brain tumor and he became such a nice person. It was so bizarre to see that change. Normally you see it the other way, but everything had changed for him. He was just like a totally different person. And I think a lot of people, when you have a loved one especially who might have had a brain injury, you're gonna see those personality changes kind of really up close. And those are some of the more challenging components to work with. Physical symptoms. So a brain injury is often an invisible illness. Most people that have brain injuries don't have those outward physical symptoms. That can present a lot of challenges when it comes to legal things like workman's comp, but also just the recognition of the disability in general. If you're just telling somebody that you have these things that happen to you, but there's no outward physical sign, sometimes people don't believe you, they don't think that it's as serious as you might say that it is. You can have some physical symptoms. A lot of times what you'll see is folks with hemiparesis, so one-sided weakness, if they had a stroke that affected one side of the brain. You might also see difficulties with balance and coordination. I think we've had some presentations about some of the visual disturbances and the speech issues that can result from brain injuries, as well as pain, fatigue, seizure disorders, sensitivity to light and sound. Headaches are incredibly common after brain injury. It's one of the most common symptoms, and fatigue is the other. So these are some things that you might see. You have an individual that you're working with that has had one or more brain injuries. So I won't read them all verbatim, but if you look at them, it's all pretty challenging stuff, right? And think about somebody that's in a substance use disorder treatment setting. If they look like they're not paying attention, or that they are disinterested, or they can't keep a conversation, what might you think about that person in a substance use disorder setting? They're not motivated.
Or they're using.
Or they're using. That's very, very common. So really we have to start to think about these folks in a different way. We have to start to look at them in this potential of having a brain injury framework, because the majority of people may have a brain injury in your treatment setting. So looking at some of these things and not just attributing them to an individual's unwillingness to participate in substance use disorder treatment or not having the motivation to be there, and thinking that maybe there's something cognitively going on that they don't have control over, that they might be displaying to you, that they don't even have they don't even. So if you're concerned that you're working with somebody that has a brain injury and they haven't reported it to you, you probably want to refer them, to their primary care, who can refer them to a neurologist. They can also be referred to a neuropsychologist to do a neuropsych eval, which is pretty extensive. It takes hours to complete. There's a lot of testing to go through. But the end result of that is usually that you have a pretty comprehensive report of how to work with that individual and what some of their specific challenges might be. So, how can this affect an individual with a substance use disorder who's trying to seek treatment? So it can just completely disrupt their ability to benefit from treatment. If they have trouble processing the information and holding on to that information and retaining it and being able to apply it in everyday life, it's going to be a lot more challenging for them to remain sober. So if you think about refusal skills, for example. So somebody with a substance use disorder, you learn refusal skills. You learn how to say no to your drug of choice or things that you can do instead, distraction techniques. Well, what if you forget all of that? And your brain just says yes, instead of thinking about all the things that you've learned in treatment and ways to say no or ways to distract yourself. It's going to be a lot harder to be successful and not have a recurrence of use. So like we mentioned, individual challenges are attributed to motivation. People may be incorrectly diagnosed with a psychiatric disorder, although the prevalence of having mental health and substance use is incredibly high. You might diagnose somebody maybe with ADHD, when in reality it's a brain injury symptoms. So some of these misdiagnoses, individuals may falsely be accused of having a setback or recurrence of use, which is kind of how we frame relapse now. Instead of saying relapse, we say setback or recurrence of use. They might end treatment prematurely, whether that treatment provider says you're not appropriate for this setting, we're going to ask you to leave, or the person decides themselves that they're not benefiting from it, and they decide to terminate treatment early. And lack of accommodations leading to the inability to achieve goals or program requirements. So a lot of substance use disorder treatment programs have requirements. You need to do, you need to attend groups and you need to go to this many AA meetings. You need to complete the homework that you get at the end of the day and bring it back to the session the next day. If somebody doesn't have the correct accommodations, which I'm going to talk about, they might not be able to achieve those goals or those milestones in order to move forward in their treatment. So the truth is, a lot of people in substance use treatment have a brain injury that's not formally diagnosed or recognized. I'm going to talk about how to screen for that. You can modify the way that you work with an individual, whether it's in a group setting, a substance use disorder treatment setting, or like I said earlier, just one-on-one. You can do it pretty easily. It doesn't cost you really anything. And it's going to help a lot of people that are in your programs. And it's going to help other people that you work with, even those that don't have a brain injury. So 3 major things that I talk about, especially when I present to treatment programs, is screen for the brain injury, provide accommodation for the brain injury, and then just focus on the person's overall wellness. Because like I said, you have those physical symptoms, you have the pain, you have the fatigue. A lot of that can be managed with some of the things I'll talk about related to wellness, and that's going to help everybody. Okay. So screening for a brain injury, it can be challenging. If you ask somebody, have you had a brain injury, most of the time they're going to say no. It's pretty amazing. We have a guy that we work with, and he's like, well, why are you guys involved? And I said, well, you have a brain injury. And he said, no, I don't have a brain injury. And I go, 5 minutes ago, you just told me you fell from a 40-foot ladder and you hit your head. Oh, okay. So he hadn't even put that together. He'd also had a stroke. I said, you have a stroke too. That's another brain injury. There's obviously stigma associated with it. There's some, negative connotations sometimes. We also work with people without brain injuries, and sometimes we call them and we say where we're calling from, and they're like, I don't want to work with you. My staff are all shaking their heads. So sometimes I'll just call and say I'm from BIANH. I won't even tell them it's Brain Injury Association. But most people, they don't want to report it, or they're not sure if what they have is a brain injury. They don't want to classify it that way. They might feel ashamed. And like we mentioned earlier, some of the symptoms can mimic signs of active use or somebody who maybe just recently stopped using. So you really have to try to tease out what is causing, the person to act the way that they're acting or how they're presenting. So there's a couple of different ways that you can kind of start this process. So you can ask them specific questions. Have you ever been knocked out? Have you ever been hit so hard in the head that you saw stars? Have you ever passed out for a period of time? Have you ever lost consciousness? Have you had overdoses where you needed to be revived by Narcan? And then those questions can kind of lead into a deeper conversation about the brain injury. Have you ever fallen or hit in your head while you were intoxicated? You can also ask if they've had specific changes in their behavior or their mood or their cognition since having an overdose or multiple overdoses. So are you having trouble finding words? Do you find that your memory is a little different? And again, that can then lead into a deeper conversation. You usually want to ask open-ended questions, not yes or no questions. You want to try to obtain the information just within your conversation, maybe your intake with that person or the first time you're meeting with them. There are also specific screening tools that you can use, and if you're working in a treatment setting, where that you could maybe make that part of your intake process. I'm going to go over those now. So this is kind of the premier tool for screening. It was developed by Dr. John Corrigan out of Ohio State University. It's a little lengthy, and I know it's probably difficult for you guys to read up on the slides, but if you really look at the questions in step 1, it's kind of what I was talking about already. So in your lifetime, have you ever been hospitalized because of an injury to your head? Have you ever hit your head or neck in a car accident or crashed in a motor vehicle? Have you ever injured your head or neck in a fall? So really some of the things that I had already mentioned, just kind of starting with those questions. You then go into, did they lose consciousness and for how long? And you can kind of come up with the score that they might have, which would indicate the brain injury or not. Like I said, it's a little cumbersome, but this is it's the gold standard for TBI brain injury screening. What NASHIA has done, the National Association of State Head Injury Administrators, is they've created this OBI-SSS, so it's basically just an online version of that tool. You input your answers into the online tool. You also ask about symptoms, and that's related to the symptoms questionnaire for brain injury. And then it'll tell you, based on what you've reported, it sounds like you have a brain injury. And if you reported specific symptoms, you'll actually get tip sheets. So the person will get a sheet on how to deal with those symptoms, and the provider that's administering the tool will also get sheets on how to work with that person and work with those specific symptoms. So you get information directly from the symptoms questionnaire on how to tailor your own working relationship and your service delivery with that particular person. So this is the easy one, where you don't have to put it into the computer, you don't have to write it all down on a sheet and total up. If you can remember HELPs, have you ever hit your head, emergency room, lost consciousness, experienced problems, or have any significant sicknesses? This is another good way that you can screen for brain injury. Okay, so once you've identified that the person that you're working with has a brain injury, now you need to identify the ways that you can best support them so that they can be successful in your setting or just in your work with them one-on-one. So there are a lot of different things that you can do. It's really going to depend on the individual and what they particularly experience. One thing we say at BIA, when you've seen one brain injury, you've seen one brain injury, because everybody is so different. The symptoms can be very similar, but the way that the individuals present can just be so varied. So you might want to work directly with the person, kind of ask them what their specific challenges might be, so that you can tailor your treatment program to them. If it's in a group setting, there's some kind of general overall things that you can do. So using concrete examples, using visual aids, allowing people, sometimes this is challenging in a treatment setting because of confidentiality and rules around electronics, but a lot of individuals with brain injuries need reminder systems, right? So they've got things on their phone that remind them to take their meds. They've got, different timers or cues that allow them to do what they need to do throughout the day. Those are compensatory strategies, things that they've developed that they know work for them in order to best manage their symptoms. So kind of allowing for that if there's, if there's an issue with electronics, maybe trying to come up with a different way that a person can use some kind of cue or alarm system for themselves. Encouraging people to take notes or use other aids that might be helpful for them. So I mentioned that there can be visual changes or visual disturbances in somebody that's had a brain injury. They might need to sit close to where you are to be able to hear you or see what if you're doing stuff on a whiteboard. So just allowing for those accommodations for folks. Repeating things, asking individuals to repeat stuff back to you, using reflective listening, breaking things down into simple kind of manageable tasks. Introducing new information slowly and kind of over time versus throwing a lot of information at people at once, which is kind of what I'm doing to you today. So just allowing for adequate time, giving people the ability to take a break. People with brain injuries, they get very overstimulated. A lot of light, sound, people, noise can be just a lot for them. So if they get up and they walk out of the room, not chastising that behavior, allowing for that, again, it's just an accommodation for that person. They might lean on somebody else in a group or in whatever setting that helps them, that kind of explains things to them, or maybe, knows when they're getting agitated and says, hey, you might need to take a break. So allowing for that interaction to happen. You as a facilitator or as a treatment professional, paying attention to those nonverbal cues. If somebody's really fidgety, looking around, looks like they don't want to be where they are, maybe giving them that permission to take that break. They might not think that they can or might be too afraid to ask. Responding to inappropriate behavior. I think that this is one of the most challenging ones, especially, people are smiling, especially in a group setting. Because if you're running a substance use disorder group, and you have somebody who's just really inappropriate, it throws the whole vibe off. And it can disrupt the group, and it can really change the course of where you wanted to go with that session. But sometimes people with brain injuries, they don't realize, again, the social cues and reading into those things, they don't realize that they're being disruptive. They don't realize that what they're saying is maybe not appropriate. And we don't want to just kind of gloss over that behavior and just move on. We do want to address it. And people are often really uncomfortable when I say to address things directly. You're not going to call that person out and shame them and make them feel bad about what they've done, but address it. Say, well, that maybe wasn't that appropriate, and maybe we could move on to talk about this, or why would you say that, or how are you relating that back to what we just talked about? Trying to help them kind of see that their own behavior maybe wasn't appropriate at that time, because they oftentimes don't realize that. People with brain injuries, sometimes they will start to talk, they don't stop talking. If you work at our office and you answer the phone, sometimes I'll answer the phone and somebody will just go and go and go. And again, I'm not trying to shame anybody, but they just do not realize that that's what they're doing. They just keep going, they've got a lot to say, and they don't understand that maybe they need to take a pause and let the other person on the other line speak. Maybe the other person has some questions to ask. So redirect that person, especially if they're monopolizing the group or they're being really disruptive or distracting to the group because they're taking up so much of the group time. Again, redirecting, addressing it, and then moving on. Oftentimes, if you're working with an individual with a brain injury, you might not follow their cognitive process. So they might start here and end up here, and you really don't know how you got there. You kind of went through all these different ups and downs to get to where they wanted to bring you. But that process kind of doesn't make sense. You're not really sure, kind of how we started here and ended up here. So if you can't follow that process, asking some clarifying questions. I talked a little bit about this already, but providing accommodations, if you're providing any kind of written information or requiring written information, you want to make sure that they can actually do that, because that might result in somebody wanting to leave treatment early if they don't feel like that they can, follow what is being asked of them, but they're maybe too ashamed to ask for an accommodation. So you as the provider might have to recognize that somebody needs that. So ensure that they can read or write. Some individuals with brain injuries, they've lost the ability to read, but they know, they know what words are, they know what they want to say, but they can't read them anymore. They might not be able to write physically. There are symptoms of brain injuries where a person knows what they want to say, but they can't communicate it to, physically they could write it, but mentally they can't tell their hand to write it. And some people just may not be able to comprehend you speaking to them or needing to read information, or may just prefer one way over the other. So again, just providing that accommodation. Especially in intensive outpatient programs, sometimes we're asking people to sit in groups for 3 to 4 hours, which is a lot. It's a lot for me, and it's definitely a lot for somebody with a brain injury. So again, allowing for those breaks, allowing people to step out if they need to step out. What's the average group size? When I used to run groups, sometimes I'd have 20 people in a group, and that's a lot. It's a lot for some people, and it's a lot for folks with brain injuries. Again, trying to pay attention to those multiple conversations. If there's some side talk in the background, an individual with a brain injury might really focus on that and not focus on who's presenting. So really just kind of paying attention to that. People with brain injuries might need a smaller group. If you're running an IOP and your average group size is 25 people, that might not be the appropriate setting for that person. And do they need any physical accommodation? So for hearing or vision, kind of being closer to the front. So the big things that are required to be successful in substance use disorder treatment, if you were in the last presentation, we learned that a lot of that stuff is housed right in the frontal lobe, the prefrontal cortex. That's attention, memory, and all your executive functioning. So all your very high level thought processes and functioning. Those things are the most impaired often as a result of a brain injury, is the attention, the ability to form new memories, recall old memories, just processing of information in general, and then being able to kind of keep it in there and retain it. Those are usually the most impaired functions from brain injury, whether that's an overdose or another type of brain injury. When we think of overdose, it's a global brain injury often. It's a general lack of oxygen to the brain or decreased oxygen to the brain, so it kind of affects the whole brain. Where a traumatic brain injury that's hit a particular area of the brain, so if it hits in the back, for example, that's going to affect your balance and coordination, and it's going to be different than somebody who had a global anoxic or hypoxic injury. So a focus on overall wellness. So again, something that can help everybody is to focus on the individual's overall wellness, not just on the substance use disorder, but what do they need? Maybe they need some individual mental health treatment to be successful in your programming. Focus on their nutrition, healthy sleep patterns. A lot of folks need co-occurring family support to be provided as part of their treatment, or anger management, exercise, yoga. I knew a guy who provided substance use disorder treatment who a required component was you had to do yoga with him. It was a little weird. He did it out on a farm in the middle of nowhere. He was an excellent doctor. A lot of people were very successful working with him, but a required component was the yoga. And my cousin, who had a substance use disorder, thankfully is 4 years in recovery, not a yoga person at all, rides a motorcycle, he's got face tattoos, and he went to this guy, and I could not believe that he was going to actually go to that doctor. I'm like, he makes you do yoga. He's like, yeah, I heard, and it helped him. It benefited him. So somehow he was able to get himself there, participate in that, which is something he would have not have ever done, and it worked. So, thinking outside the box, sometimes you might need to try things that you wouldn't normally have expected for yourself. Okay, so I'm going to talk, we have a couple of things going right now. Is Robin in here?
Yeah.
Robin Shell? Oh, thank you. So Robin Shell is a consultant. She works a lot with the Brain Injury Association, and she helps me with a lot of these grants and projects that we're working on. So we have a pilot project with St. Joseph Hospital. It's actually coming to an end at the end of June, when the fiscal year is over. But it was funded by a grant through the Foundation for Healthy Communities. And basically the idea was, let's partner with folks in the ED. Let's identify people that are coming in with an overdose. Maybe see if they've had some cognitive changes and try to work with them, get them connected to treatment. So I don't know if you guys have, had a lot of experience working in the emergency department or been there when you've seen overdose patients come in, but like I mentioned in the beginning, a lot of times they don't want to be there. So they've been Narcaned in the field or they've received Narcan in the ER, their high is gone. They want to go back out and they want to get that because they know that they're going to start to withdraw pretty soon, they're going to start to feel pretty uncomfortable, and they really don't want to be there addressing any kind of substance use component. They've just overdosed. That's not the time to really try to delve into all of that stuff. So we have a very limited window of opportunity to really connect with those folks when they come in. And a lot of times it's a social worker going in there like I used to do and say, hey, I know that this is not a great time to talk about all of this. Give me a call when you're ready. I didn't get a lot of follow-up calls. I'd give my business card. Every once in a while I did, but not often. So the pilot project was designed to follow up with those individuals after they left the hospital. So we made that connection for them if we had a neuro-resource facilitator in the hospital once a week. So if he was there, he would meet with the patients directly and give them his name, his business card. He'd try to start the conversation, but a lot of times, again, individuals don't want to stay. So they would leave and he'd follow up with them a day or two later and kind of continue to follow up with them over time. Help them get into treatment. What are some barriers to treatment? What are you having challenges with? How can we address those things? So just that ongoing follow-up and support. The emergency department providers learned a protocol for screening in patients that met this criteria. And they would refer to the neuro-resource facilitator. Either if he was there, like I said, he'd meet with them, or they would send him a secure message. And then he would follow up with the individuals outside of the hospital. We eventually kind of expanded this to other areas, to the inpatient units. There's also a mobile clinic that they're running now that we were kind of trying to expand to. Unfortunately, our neuro-resource facilitator ended up taking a full-time job, so he left. And that's kind of resulted in a lack of referrals coming directly to the organization. Although we are still happy to take them, it doesn't have to just be from St. Joseph's, it can be from any hospital. If you want to call us, we can provide support in that area. I think, what we found from him when he was, directly meeting with folks and getting those referrals, he was able to make connections with people that weren't happening in the emergency department setting. I think people have gotten better over time, but as a social worker in the emergency department, I saw a lot of stigma around folks that came in with overdoses or just drug-related concerns. The nurses are like, I don't want to deal with this is not what I signed up for. Even some of the paramedics, some of the comments they would make, it was really disheartening. And as we saw a rise in overdoses and a lot of people utilizing emergency services, it just caused more and more burnout within that field. I think people just started to not feel compassionate for folks anymore that were in that situation. And so not as motivated to help them in that setting. Really treat them and get them out of here. We had a doctor at the ER, treat and street is what he would say. Not just about the overdose patients, anybody in the ER. Treat and street. We treat them and then we send them to the street or back to their home. But that was the kind of the old school way of thinking in the ER, Get them all set and get them out of here. Again, healthcare, the way that healthcare goes, it's a revolving door. You have people coming in, there's a lot of demand. There's no beds in the hospital. These individuals who use substances or had psychiatric concerns, they were taking up a bed meant for a medical patient. So doctors, nurses, oftentimes they don't want to deal with this population. So having this neuro-resource facilitator, I think, was really crucial. Give it to Sam, that was his name. Give it to Sam and he'll follow up with that. And then it's not something that they have to deal with.
So Krystal, what does the future look like after this grant runs out at St. Joseph?
So the future looks like we're still taking referrals. I'm trying to make the rounds to a lot of different hospitals. Obviously, St. Joe's knows about us. We have a pretty good partnership with St. Joe's because I had worked there before I came to BIA. Their executive director of their emergency department, Dr. Vadi, I kind of recruited him over to BIA because I noticed how compassionate he was with the individuals I worked with in particular. And I noticed that he didn't do the treat and street thing. He was, all about helping these individuals and working really closely with them. So when we had an opportunity to come up with this kind of grant, that was who my brain went to right away. Like, let's get Dr. Vadi involved in this because I know that he's somebody that will actually care about this population and want to do something about it. So we've got a pretty established system with them. I've gone to Elliott Hospital and done a presentation for them. I'm hopefully going to go to Wentworth Douglas. I've talked to some people at Huggins. So really trying to go around to the different hospitals and let them know we exist, because we've been around since 1983 and a lot of people have never heard of us. So we exist. We are the premier resource in the state for individuals with brain injuries. And if you have somebody, even if you don't know if they have a brain injury or not, whatever they might have going on, they can call us. And it's on us to figure that out, kind of tease out what would be best for them right now.
Can I just add a couple things to that as you're talking about the future of this? So they've already kind of gotten into the behavior of asking some of these screening questions, and I think Dr. Vadi's phrase for this is it's baked into their culture now. So even if they don't ask every single one on the John Corrigan tool, they've got a system going where they're noticing it and they're, at least recording it in the system. And so, yeah, we'll have to see how it goes going forward, but at least some of those behaviors are in there.
If you've worked in a hospital setting, if you've worked in a hospital setting or worked with discharge planners, even just think of your own loved ones that go into the hospital and you get a call from a discharge planner and they are trying to come up with a plan. That person needs to go. They've got limited time in the hospital and they need to get out of here. If you give them a resource that they can put on their discharge summary, follow up with the Brain Injury Association, that satisfies a lot of their needs oftentimes. They have somebody else on the outside that's going to follow up with that person related to a concern that you might have or why the person was inpatient. And they know that when they discharge that person, that there is, at least they give them the information, even if they don't follow up. If they give us the information, then we can follow up with the person. So, sorry, what was your question?
Okay. I have a client that has an anoxic episode, had some paralysis. He's been in treatment centers over 10 times over the last 2 years. Cannot stay sober, lives with his parents.
Yeah.
I'm thinking he's probably there. I haven't heard from them, so I'm thinking he's probably in another treatment center. So he completes treatment, I'm assuming, when he goes to California, so who knows?
I know. Well, that's
they
what I was
might
gonna
just
say.
bill, I don't know. He just can't do it right now. So is there anything for parents, because they unfortunately enable, they don't know what to do. So they protect and shield him from really the reason why he's in this situation is because he overdosed. So
Sure, I know.
It's horrible.
And
It
his
really
parents
is.
continue to fund the treatment.
Yeah, it's under their
That's
insurance. I don't know
not
how their
successful.
insurance covers all that, to be honest. It's really, he goes away for like 30, 60 days.
Yeah.
So, I don't know. Can they call just to kind of get some support?
Absolutely.
I kind of refer them to Al-Anon, but they have.
Yep, absolutely. So always happy to work with families, parents of survivors of brain injury. I'd be happy to talk to his treatment center and see, because I think he kind of goes to the same place, or he at least goes to California all the time.
California. I think he went to Mass the last one or something. Yeah. But
So I'd be happy to talk to him, to his parents, or to the treatment center specifically and kind of say, what are you seeing? Or even just asking him, what is causing you to relapse? Like, what are the triggers here? Because I'm sure he identifies them in treatment, but then I wonder when he comes home, how much of that treatment that he learned, how much is he retaining? just at this point, I mean, with the initial brain injury plus the repeated overdoses.
Yeah, he can't sit for more than 15, 20 minutes and talk to you. You know, he's like,
And
oh, okay, and he walks.
That's probably one of the
So,
challenges
yeah,
too
so-
in treatment.
Yeah.
Unfortunately, I think his situation is pretty common.
Is it?
One of the presenters said, the average person has a recurrence like 15 times over the pattern of their
Wow.
usage. So going to rehab or treatment centers, think of that 15 different times.
And there's no treatment center specific for for brain injury?
No. So people call the office and ask me this question like almost every day. You probably get it a lot too, huh? Yeah. Is there a place that this person can go that hasn't, they're specialized in brain injury but also in treatment for drug or alcohol use, and that doesn't exist. So that's why we're here, to provide and be a resource to the different treatment centers. That's why we're doing these trainings. We're trying to get the word out. We're trying to say, hey, we're here, call us. We'll come and do a training for you, or we'll just talk you through some things over the phone and give you some tips and pointers on how to work with that person and be more successful.
Yep.
So no, there isn't a specific place. I don't know if I'm in favor of that or not. It can kind of go either way on it.
Even like a track, just.
I mean, having a clinician embedded into a
Yeah.
treatment program that understands brain injury is probably very helpful. I don't know that having like an isolated just for brain injuries and substance use disorder, because it's kind of what you have now, because so
Yeah.
many people in treatment have brain injuries. So we have another grant. It's a grant with the Bureau of Drug and Alcohol Services, so BDAS. Again, similar, it's a grant for brain injury and substance use disorder support. So it's allowed me to go around and do a lot of trainings. It's allowed for us to offer this track at the conference. I have presented in all kinds of different places, getting to know a lot of different people, which is really cool. I have people now calling me because they saw me at a conference or they heard about us through the grapevine from other people I presented to. So it's really starting to grow our connections with some of the community agencies that are working with these folks. I have a presentation in a couple of weeks for a jail, which I haven't done one of those yet, and I'm so excited because I think like 90% of the jail population has a brain injury.
I work in a correctional setting, specifically with people with mental health issues, and this was so pervasive. So pervasive. It's exactly what you're talking about. Do you have a brain injury? No. Well, you've been knocked out? Yeah, like 3 times.
Yeah.
You're like such a pervasive issue.
Yeah.
It's awesome to hear that you're getting into that system.
Yeah, so I'm going to Carroll County House of Corrections in a couple of weeks. And I'm hopeful that from there, I can start to branch out into some other correctional facilities. BIA is going to be doing some work directly with the correctional facilities coming up, unrelated to this grant, but really just trying to, provide education to folks in those facilities on these are the people that you have here, whether you know it or not, and here are some ways that you can work with them more effectively. I've done presentation, Robin can probably remember my presentations better than I can. Like I said, I went to Elliott Hospital. I went to the North Country Home Health Consortium, did one there. Seacoast Public Health, we did one there.
And educators, you've talked to them?
Oh yes, I did one for the educators. I did one for a group of educators that are specifically focused on student wellness. Trying to think of all the other ones. I've done a lot. I've done this presentation a lot of times. There's many iterations of it. So again, hoping to continue that work. BDAS only asked us to do 6. I think I've done like 20. So, and I want to do that. I want to keep getting the word out. I want to keep doing the presentations and helping people make that connection. We also have a resource center on our website. We have a monthly blog. So Sam, our neuro resource facilitator that was working at St. Joe's, he's still doing blogs for us. They're on our website every month. And also just kind of working on our website to provide more substance use disorder resources, whether that's treatment resources or even just information. Trying to beef up the website a little bit, that section of the website, just to have it be a go-to resource center for folks. Written materials, we've developed what we call rack cards. They're on our BIA table that's over by where you registered. I encourage you to stop by and pick up one of them. There's 3 versions. All the information is pretty much the same. It's just tailored to different audiences. So we have one for medical professionals or treatment professionals. We have one for survivors, and we have one for teens/educators. So the teen educator one is green, the other two are both blue, because I didn't really think that one through. So probably the next round we'll make it a different color. And it's got a QR code that links to our website, that links to this resource page. It's got some information about overdose. It's basically this presentation in a very small snapshot on an easy to read, kind of bright glossy card. We were giving those out. Were the rack cards in the Seacoast and the overdose kits?
Yes,
Yeah.
we did. We worked with the Department of Safety on their trainings to get those in the overdose kits at one point. And we're talking more about it, so we're spreading them around. The New Hampshire Providers Association kind of picked up on that work, and they have a whole
Right,
section
they
on
have,
their page
we worked with
too.
their intern
Yeah.
to develop that section, yeah. We've had tables at conferences where we're giving this out. We were at the, because I'm a social worker, we were at the NASW Jedi Conference in December. We'll also be at the one in a couple of weeks, the annual conference, Memorial Day weekend right before. We've had a table at other places too. Just really just trying to, hey, we're here. We can give you information, we give you resources, follow up with us, we're happy to help. Even if the person that you're working with, you don't know if they have a brain injury or not, again, refer them. We're happy to kind of talk with you, talk with them, see if we can help figure out what's going on. As I'm giving Jen a lot of work and advertisement for her, but that's okay, I'll help you. Okay, these are the rack cards. So this is the one for survivors. So it talks a little bit, I'm going to use my laser pointer. It talks a little bit about signs of a brain injury here. Just some things to think about why an overdose causes a brain injury. So it goes into the brain stem, it can slow or stop breathing. Some harm reduction stuff on the back here to kind of prevent overdose. So carrying Narcan, staggering use with somebody, so if you're going to use with another person, not using both together at the same time, so that way if somebody does overdose, there's somebody available to call 911. Knowing the signs, carry a rescue breathing mask, those come in the overdose kits. I think they come in the Narcan kits that they give out too. They give a mask in case you don't want to do any rescue breaths without that protective barrier. And also linking here to the doorway, just kind of showing folks that that's kind of the major resource center now for substance use disorder treatment and Narcan. This is the one for professionals. Again, next time we'll change the colors. Goes over what we talked about here, so screening for the brain injury, accommodating for neurobehavioral deficits, using a holistic approach, creating supports. And this is the one for the teens/educators. We added pictures to this one, kind of trying to make it more catchy for teens to look at. And this really relates brain injury from overdose to brain injury from concussion, because that's such a huge problem in youth sports. So if you had a concussion, did you notice these things? Well, that can also happen if you have a brain injury from an overdose. And this is for teens, for educators, and it's not just teens who are using, but teens who might have parents who are affected by a substance use disorder. These are where I got some of my information. If you want the links, I can send them to you. I think the PowerPoints will be available. And if you want a training directly at your place of employment, you can contact me. I have some business cards. There's also, if you go to our website, we made a section on the substance use disorder page of the website where you can request a training, and that comes directly to me. So you put your name and where you work and kind of what you're looking for, and I'll either do a virtual or I'll come out to your site and do a specific training for you. I did a 4-hour version of this training. I kind of flew through this because I know I only have an hour. I could spend a lot more time on a lot of these slides and some of the accommodations and the behaviors. So I don't have to come and do a 4-hour training, but I can do an expanded training of what we kind of started talking about here today. And you can call our main office. This is our main office phone number. We also have the 1-800 number here, out of state, toll free. And yeah, I think that's it. Are there any questions? Nothing? Yes, go
I
ahead.
could just a comment. This is great. This topic's so important, and you did a wonderful job with it. I think a lot about how people get labeled as non-compliant and like the how that impacts access to treatment and all of those things. And I think like this is a perfect example of a piece that's missing for a lot of people that they're not understanding.
Absolutely.
I hate that phrase, but yeah.
When I started in kind of in the field, I was working at a unit that had a detox, a rehab, and an intensive outpatient, and I did the level of care evaluations. And so people used to call me, hey, do you have a bed? Nope, call back tomorrow. So they had to call every single day. And if they didn't call every day, we were like, well, they're not motivated to attend treatment. It's like, when you really think about it, I don't want to call a place every day and keep asking the same question and keep getting told, no, there's no bed. You know, that's disappointing. Like, I want to give up. So, and that's really an old school kind of way of doing things. And I think some places still operate that way. But really just trying to think about it and what I presented, like somebody just might not have that ability to even do that, to have that follow-up and that initiation. Yes?
Are you aware of any work being done now on any kind of resources in the community that for people to access after they get out of treatment? I think getting into treatment and trying to ask a head injury person to go to groups and, you know, where they're confronted on honesty and motivation is, I think it's a terrible model for them. And then, you know, the follow-up so often is AA.
Yeah.
And, you know, AA is fantastic, except when...
It's not for everybody.
Right, if you have a problem sitting still and you have a problem, you know, understanding stuff, and, you know, you have people in your face telling you that you have to, you know, admit your faults and pray to God, you know, it can be difficult. So I'm just wondering if you're aware of any resources where people are kind of molding some outpatient stuff for...
Yeah, I mean, in that vein, there are smart recovery meetings, which are less focused on the, you know, the 10 steps and the religious component of AA and NA, and more focused on, you know, kind of managing behavior, changing behavior. So they're called smart recovery. But as far as what you're asking, I don't think that there's a lot out there in that vein. So I'd like to see more of that. I think in our support group specifically, we're starting to see more folks that are there with a brain injury because of a substance use disorder. Have you heard that from some of the support group leaders, Ellen?
Yeah.
Yeah. So, you know, I think that a lot of times they would go over here, you know, they have to stay with the other addicts, and, you know, brain injury was very separate. So now we're kind of realizing that there's considerable overlap. So having them in it's a brain injury support group, so you can be there. We might not be talking about your substance use, but again, that overlap. There's a lot of people in those groups that, you know, maybe aren't there because of a substance use related brain injury, but have a substance use disorder. So I hope that we get there. I just don't think there's a lot out there right now, and if I'm missing anything and anybody knows of stuff, let me know.
There are some places like, and the name escapes me, but Manchester has I would call it a drop-in center that's, they're obviously recovery focused, but it's not, they're trying to be low barrier to entry. So they can have people, you can come into the groups, you don't have to participate, you can go in and just do like a painting group or a games night, but obviously the goal is to get people with shared experiences from substance use or recovery just to participate in something to then maybe get to some next step from there.
I think we had a couple of those pop up a couple of years ago. Some of them just didn't have a lot of funding and ended up having to close. So I think that becomes a big part of it, is the funding. I know that we have some of the opioid abatement money, you know, in the state now. So hopefully, you know, places are able to utilize that and maybe, you know, develop some of the programs that you're talking about. But yeah, I hear what you're saying. It's like the 90 and 90 is not always the way to go, you know. Other questions? Yes.
Were you able to get good data on your St. Joe's partnership with the...
That's a Robin question.
Yeah, so we actually, right now, because we're coming to the end of it, we are going to do a post-training test now that it's been going for a while, so that'll include anyone who's gone through the training. And we do have some very behavior-focused questions in there. There are some about compassion fatigue, but there's also some, how many times have you recognized brain injury and referred it over, and how many times have you done some of those behaviors, so we will have some data. The barriers that we faced are, especially the medical frontliners are really busy, and to
Yeah,
get them
this
to
is not
fill
their
these surveys
main
out
focus.
is tough. We did the QR code thing and we did the best we could, but we'll be able to measure how behavior has changed. And we've done it with some other, there was a small training for some of the EMTs,
Oh, yeah.
and so we've got, that little group. And so, our hope was this was a pilot, let's learn from it, and hopefully other hospitals will embrace it and build on the model. That was the idea.
Also, staff turnover at
Yeah.
hospitals.
Yes,
So I can
that
go
too.
around and do a
Oh,
training
yeah.
for every single hospital in the state,
Yeah,
and
yeah.
then that social worker in the ER might not be there.
Yeah.
So we're hoping that by reaching as many people as possible with this information, that it kind of gets passed down, and we just become kind of part of, like you said, part of their routine of referral or,
Mhm.
in their discharge.
And making it a part of the debriefings and the staff meetings, just making it easy, that's the key.
A lot of times when I do these trainings, that there's like multiple light bulb moments happening all around the room.
Yeah.
People are like, oh yeah, of course, but I hadn't
Yeah.
thought of it, I hadn't put those two things together.
Mhm.
So if people find some use in what they're learning, they're more likely to then share that information with their colleagues or make referrals. So we have had some people be pretty successful from the follow-up that we've provided at St. Joe's. So hopefully we'll start to see more of that and people can realize the benefit and the value.
Thank you, Krystal.
Thank you.